motility. I'm going to talk about evaluating effectiveness for new technologies in AFib ablation device trials. I wanted to convince you that FDA is interested in new ideas and consensus is needed to help better define success. So by way of background, pre-market studies are required to support FDA approval of new AFib ablation technologies. And the goal of a pre-market study is to demonstrate reasonable assurance of device effectiveness and safety for its intended use and patient population, which is the statutory standard for pre-market approval. I'm not going to bore you with the language here. I wanted to point out that for determination of effectiveness and safety, FDA expects a pre-market study to generate valid scientific evidence for clinical benefits from the device used in the intended population. So how is the pre-market study being constructed to demonstrate effectiveness? Using RCT as example, patients who meet the study eligibility criteria are randomized to receive either ablation using the study device or a control therapy. Then the desired treatment effect will be assessed by evaluating a variety of outcome measures that include at least one primary outcome measure for which the trial is powered and then a few secondary endpoints. Then the randomized control design will allow us to attribute the treatment effect to the study intervention. This is nicely illustrated in the STOP-AF first trial, that is the randomized trial that supports the FDA approval of a cryoballoon catheter to treat drug-naive patients with symptomatic paroxysmal AFib. The study demonstrated the device effectiveness by demonstrating the superiority of the cryoballoon PVI over AED therapy in preventing atrial arrhythmia recurrences, which is a key component of the primary endpoint, and then also improvement in patients' quality of life measures, which is the secondary endpoint of the study. So in previous studies, ablation success often requires freedom from AFib recurrence of 30 seconds or greater. This definition reflects the goal of AFib elimination, and it has been widely used in AFib ablation trials and allows for the use of performance goal for evaluating new devices in single-arm studies. On the other hand, it has been increasingly recognized that the 30-second metric may underestimate the benefit of AFib ablation through significant AFib burden reduction despite AFib recurrence. As shown in the circle dose study here, in which an implantable loop recorder was used to detect AFib recurrence, while only about half of the patients had no AFib recurrence post-cryo RF ablation, AFib burden was reduced for more than 98% at 1 year follow-up. So what is the better metric to define success? Unfortunately, it remains an unanswered question as noted in the new ACC AF guideline. One of the areas of great interest is to use significant AFib burden reduction to define success, because it aligns with one of the goals of AFib management, and also with advances in monitoring technology, it's now possible to accurately quantify the true AFib burden. To allow the use of AFib burden reduction as the primary outcome measure, we need to find consensus on measuring AFib burden and measure burden reduction, because investigators have been using a variable definitions to define AFib burden. Another challenge is that the threshold for defining significant AFib burden reduction has not been well established, and the threshold should be predictive of clinically meaningful outcomes in the target population. So what are the considerations in selecting primary outcome measure? Similar to any pivotal studies, the primary outcome measure needs to be able to reflect the primary objective of the study intervention. It needs to be clinically meaningful and can be measured objectively with minimal bias. And for device approval study, it's important to tailor the primary endpoint to the intended population. For example, for studies to support indication of treating patients with symptomatic AFib, objective measures of reduction in AFib recurrence or burden would be the desired primary outcome measure. The challenge is how to define success in patients with AFib recurrence. We don't have a silver bullet, but a few metrics may be considered to start a conversation. For example, treatment success could be achieved through a clinically meaningful AFib reduction on continuous breathing monitoring and the elimination of persistent AFib episodes. Evidently, the burden reduction strategy needs to be supported by evidence of corresponding improvement in AFib symptoms. Other metrics like freedom from episodes of atrial arrhythmia requiring interventional consultation may provide an objective measure of symptom burden. For trials to support indication of treating patients with low symptom burden, the primary endpoint needs to be defined to reflect a clinically meaningful benefit beyond AFib symptom improvement. Would that be improving cardiovascular outcomes, improving heart failures, or something else? So I hope I've convinced you that if we wanted to move beyond the historical definition of success, we need to find consensus on important issues such as definition of ablation success in AFib, in patients with AFib recurrence post-ablation. The FDA is open to new primary outcome measures with a valid justification. And finally, for studies using new primary outcome measures, we recommend well-controlled studies because there are no established performance criteria for those parameters. Thank you for your attention.
Thank you. We'd like to